So now we come to part 6, in which we're going to cover the natural history of malignant oral lesions. So we're really going to talk about oral cancer. Now you'll have seen this schematic diagram earlier, which takes us through from the white patches with no dysplasia, dysplasia, and then into invasive lesions, which is squamous cell carcinoma. Now, as I indicated earlier, this is perhaps a little bit of a simplification, or perhaps even a little bit misleading, because it presents this as a one-way street. We've already seen that some of the precancerous lesions may regress. And also, at times, we see lesions that, invasive lesions, which develop in mucosa that looks relatively clinically normal. So there are a lot of other things going on in the natural history, but we're going to really present this as this sort of continuum just for ease of some understanding. So here's a lesion, the sort of thing we might be talking about. We have a large exophytic mass. It looks as if it's probably centered on the retromolar area, anterior pillar of fauces, tonsil sort of area. It is exophytic, it's coming out from the surface, it's got that red and white mixed appearance to it, perhaps down the side of the tongue. It's got a kind of ulcerated appearance with a kind of yellowy slough. And then if we were to take a biopsy from that, we would then get the appearances. We would see that there is epithelium, which is invading into the underlying connective tissue. It has escaped the confines of the basement membrane, which is still intact in dysplastic lesions. And the epithelium is extending into the underlying connective. It is invading, and that is the hallmark of a malignant disease. It invades. Cytologically as well, all these different variations, cell shape and size, mitosis, all these sort of things we talked about in dysplasia, they are also present when you take a biopsy, and you will see them. So what are the things that we are looking for when we're thinking of oral cancer? What should we be explaining to our patients, the things that they should be aware of, so that prompts them to come for an early referral? Well, here you see in this slide here the list of the signs and symptoms. The list of symptoms you can see is relatively short actually, and perhaps the most important one of these is the fact that a good proportion of patients, particularly with early oral cancer, will come to you with no complaint at all, no symptoms. Some of them may have some amount of soreness or irritation, for example, an ulcer that's been a little bit annoying that's not healed. But the others, paresthesia, anesthesia, that's alteration in nerve sensation and so on, it's a late change. Disruption of function, for example, can they move their tongue? Is it going to affect their speech? Or dysphagia is that effect on invasion into whatever structure of the head and neck, which means that the patient has difficulty swallowing. And these are particularly features of advanced disease, as are, for example, a patient who come in and say, I've noticed this mass in my mouth, like was in scene you saw in the previous photograph. And so that is something which is a very key message to try and get across to patients, that anything, even how insignificant, must come and so it can be looked at. The European Head and Neck Cancer Awareness Campaign talks about things as being 1 for 3. So if you get any one of these symptoms for more than 3 weeks, you should be attending your dentist or your doctor to have a referral made so that it can be assessed. But it can be challenging if there's not really very much for the patients to go on. So what about signs? Well, these are the things that you're going to notice potentially at your examination. So the patient may have a persistent ulcer, and obviously an ulcer comes with a differential diagnosis. It has a lot of things you'll have seen in the earlier part of the course. It could be trauma, it could be an underlying hematological deficiency and so on that predisposes to ulcer. So there are a number of things to consider. Persistence, red, white, or mixed patch. Again, we've talked about erythroplakia and leukoplakia, but there are other lesions which may give you white, red, or mixed patches as well. So they all need to be taken into account. Exophytic mass. It is a mass that's extending up from the surface. The patient will very often be aware of it, but many patients tend to have these and kind of ignore them. Fixation of tissue, so you're going to get perhaps the patient will be difficult moving their tongue and so on. Induration means that it's hard to the touch. You can't really get the idea of induration just by looking at a clinical picture. It is something that you need to feel at the time of your clinical examination. And then sensory or motor deficits. Sensory being perhaps if you were to test the innervation of the area of the mental nerve, and you see that there's sensory deficits when you do that, or motor deficit in terms of the functions of muscles around the face, and particularly muscles of the tongue. If the lesion will involve the gingiva, you may well have tooth movement or mobility of teeth if there is destruction of the gingiva. And then lastly, which we will talk about in some detail, lymph node enlargement and fixation, which is obviously very important in terms of the spread of disease, and it's in fact very important clinically as a marker of prognosis. So what are we looking at? Well, here is an ulcerated lesion. It looks to me as if it is probably on the anterior part, maybe of the soft palate, although it's difficult exactly to see exactly where this is. It's got slightly raised margins, and there is no particular back. It's a bit red and white in the background there. I don't think there's anything there that would definitely say that's a malignant ulcer. There may be a lot of background clinical information you want to gather from the patient. How long has it been there? Has it changed in size? The usual ulcer history that you would need to pursue in regard to that. But here is a lesion, an ulcerated lesion, which would cause you some concern. And in this case, it's on the gingiva. It looks as if there's quite a large background white and red lesion there, but also there is a rather large sloughing ulcer. It just looks angry. Looks as if it may be involving underlying connective tissue and perhaps even the bone, and that is an ulcerated lesion on the gingiva. That would be very concerning. What about red and white patches? Well, we've had a look at these on the way through. And the lesion, which is on the left of your screen, that is a large mixed red and white patch. It is an erythroleukoplakia, and that would be a lesion because of its site. It's a high-risk site, and its appearance would be one that would concern you quite considerably. But they can be much more subtle, and you see the lesion here on the right-hand side. Again, much harder to define, has got a slightly kind of raised, velvety appearance to it. It's not particularly red, and that is going to be more difficult to see in your examination. But it also on biopsy was dysplastic. Here's a white patch with thicker areas towards the dorsum of the tongue and thinner areas towards the ventral surface. And that lesion actually, particularly towards the back end of that, had some early invasive carcinoma. And here's a lesion on the alveolus, a classic erythroleukoplakia, lots of white and red mixed together. And this also was a lesion which, at the time of biopsy, was an early squamous cell carcinoma. We've mentioned erythroplakia in the way through. You've seen this picture again, and it's just to reinforce the point that for the red lesions, you have a far higher risk of malignant transformation, and a good proportion of them will already be invasive at the time that they are biopsied. Then you do come to lesions which are very similar to that lesion in the retromolar area, which I showed you a few slides back, and this one here, where you have a large exophytic lesion. And at times you wonder how patients put up with these developing in the mouth, but they do. There are very many reasons why patients do not present at an early stage, which we don't really have time to go into. But you can see a large destructive and exophytic lesion here, which seems to be involving the anterior part of the maxillary alveolus. When tumours get very large, they will begin to invade and destroy the underlying tissues. And here's a patient who has a large cancer which is centred on the floor of the mouth, and that tumour is invading into the underlying muscle of the tongue, and it stops the functioning of the tongue. The tongue itself becomes hard, indurated, but it will also stop the movement of the tongue, so the patient will then maybe report alterations in speech, or even at a later stage, finding difficulty in swallowing. And some of these large tumours, like you can see here, this looks like a large crater which is present in the anterior floor of mouth, extending into the lingual gutter. And this patient had a lesion which was largely covered over by a denture. It wasn't really very evident at all. They weren't really reporting any particular problems, but you can see that there's a large lesion which is centred on the floor of mouth. Again, here is another lesion which looks as if it's centered on the retromolar pad area. Not an awful lot to see on the surface. You can see in the retromolar pad there's an area which looks a little bit, it's a bit of a white patch, it's a red area, but not particularly significant. But this patient was suffering from a bit of dysphagia, And what we can see in the next picture is the MRI scan. And you can see here on the MRI scan, particularly on that side here of the tongue, here's a large lesion which is extending through the body of the tongue, almost through the midline. It's involving a bit of the mandible, a rather large and destructive oral cancer. It is important to remember the kind of rules of thumb in terms of the sites which are particularly important. We are trying, if possible, to identify these cancers at as early a stage as possible. And so the risk does vary by site. We've talked about that already. The floor of mouth, ventral surface of tongue, lateral border of tongue, that whole area is a really important site for early oral cancers. And in the retromolar region, soft palate and fauces. So these two particular areas in the mouth, the vast majority of early oral cancers will be there. And if we can get patients to present a bit earlier, and we are also doing systematic examinations of the oral mucosa, it may be that we will be able to pick up more of these at an early stage. But it is important not to forget the rest of the oral mucosa, the gingiva, the buccal mucosa, the labial mucosa, the hard palate, the dorsum of the tongue. Yes, these are much rarer in terms of the development of oral cancer, but they must still be attended to. The last thing on that list in terms of the clinical examination, the natural history and things to look out for were lymph node metastases. Now this is very important. 50% of patients who present with their oral cancer will, at the time when they present and have their diagnosis made, lymph node metastasis to regional lymph nodes in the neck. And you can see in the picture here, there's a patient who has a very obvious lesion on the left-hand side. Sometimes it is obvious and you can see it clinically. Other times it's not. And you may have to get practiced at doing a good examination of the neck for your patients, making sure you know where the main lymph node groups are, largely down the anterior part of the sternomastoid. And we don't really have time to do that, but you get a chance to do that in the more oral medicine clinical part of the course. So what are we looking for in terms of lymph node metastasis? Well, painless enlargement of a lymph node is something which is common. The patient may comment that they have noticed this, or they may not. You may find it on your examination. Painful enlargement does tend to suggest a reactive process. So a patient who has an upper respiratory tract infection, has a dental infection or so on, if they have a lymphadenopathy, it will tend to be tender to touch. But metastatic nodes tend to be painless in their enlargement. Tend to be rock hard. So they're really very firm to touch. If you can at least get some sort of bimanual palpation on them, if they're large enough. And then there's a particular problem which really moves things on a step from that, which is fixation to the underlying tissues. Now, normally a lymph node, you will be able to move it within the tissue plane in the neck, between the skin and the subcutaneous tissues and the muscle layer of the neck. But once it begins to get stuck either to the underlying tissues in the neck or perhaps even to the skin, that means that it's possible that the tumor has grown, it has overtaken the lymph node and is now growing out of the lymph node into the surrounding connective tissue. And that, again, comes with a further particular problem in relation to clinical outcomes for patients, which I'll talk about more in the next section. So here's the sort of thing that you might see on the left-hand side. There is an enlarged lymph node there. It's relatively subtle, but you will see everything all the way through to those, you can see on the right-hand side, where there's a very obvious mass in the neck. The rate in which you get lymph node metastasis does vary depending on the site. Now, this is from Julia Wogar's data from Liverpool, and you can see I said 50%, 47% overall. It is about that, but it varies. The ventral tongue and the lateral tongue and the oropharynx are quite high. The tongue tends to be high mainly because of the orientation of the muscle fibers. You get a deeply extending tumor quite quickly in the tongue, and that raises your risk of lymph node metastasis. Oropharynx and other retромolaries are far back, so they tend to present a bit later. The tumor may well be a bit bigger. Again, that gives you a greater risk of lymph node metastasis. But those in buccal mucosa and on the alveolus, the gingiva, much lower in terms of the risk of metastasis, although that is still there. The one thing also that's worth commenting, I suppose, and that relates to oropharynx, is that patients who have HPV-related oropharyngeal cancer, they do tend to have a very high rate of lymph node metastasis. And that doesn't seem to have the bad prognosis that goes along with the smoker-drinker cancers for reasons that we're not entirely sure of. But so it's very important, again, that you are examining the neck in your patients as part of your routine clinical examinations. And the next step on from lymphatic spread is blood-borne spread. Now, this tends to happen at a late stage in head and neck cancer, but to some extent, as we have been getting better at treating head and neck cancer and getting patients to survive a bit longer, we do see more systematized cancer in oral cancer and head and neck cancer generally. It's a late event. It tends to be related to advanced disease, sometimes related to recurrence of disease. And with it, it carries a poor prognosis because by this time, the disease has become systematized. So it most often is going to the lungs or occasionally to the liver or to the spine. And it may be that the tumour is getting out of the lymphatics directly into the blood, or the tumour itself might be invading into blood vessels. And so you get the blood-borne spread.